Yes, yes. The topic from the respiratory department. I am Dr. Rakesh, assistant professor from respiratory department. So today's topic is about Loeffler'S syndrome, pulmonary eosinophilia, also called as simple pulmonary eosinophilia. So in this pulmonary eosinophilia, simple pulmonary eosinophilia, also called as Loeffler'S syndrome. So here, this illness usually lasts less than 2 weeks and always less than 1 month, and is related to the passage of the parasitic larvae, most commonly the Ascaris lumbricoides, through the lung. So the infective agent is the Ascaris lumbricoides. There is a parasitic larvae of the Ascaris lumbricoides. The illness usually lasts less than 2 weeks. Now always it is less than 1 month. So in this, the chest X-ray, radiographically, there will be transient radiographic shadows throughout the lung fields. And there will be increased blood eosinophils. There will be increased peripheral blood eosinophils. So even the increased eosinophilia in this Loeffler'S syndrome is usually slight, but sometimes even it may be elevated even to higher counts also. Etiology. Life cycle of Ascaris lumbricoides in humans begins with the ingestion of the eggs and subsequent development of the larvae in the intestine. Some 10 to 14 days after the ingestion of the larvae migrate to the liver and the lung. Hence, in the lung, in the alveoli, through splanchnic circulation, they enter into the alveoli of the lung. Okay, from the alveoli into the bronchial tree. And from the bronchial tree again they will come into the upper respiratory tract. They will come into the upper respiratory tract, and from the upper respiratory tract, this larvae can be aspirated and swallowed into the intestine, where they develop into mature round form. Immune hypersensitivity to Ascaris lumbricoides has been recognized as the likely cause of the most of the earliest reported cases. Although several other parasitic infections and exposure to numerous drugs and other agents have also been recognized to induce a Loeffler-like syndrome. So not only the infestation because of the Ascaris lumbricoides, the immune hypersensitivity reaction developed because of Ascaris lumbricoides is recognized as the Loeffler syndrome. Even some other parasitic other infections and exposure to some other drugs are also recognized. They also may mimic as a Loeffler-like syndrome. But the typical Loeffler'S syndrome, also which is also called a simple pulmonary eosinophilia, is caused by the Ascaris lumbricoides. Clinical features: cough is the most common symptom. It is usually dry, unproductive, but may be associated sometimes with the small amounts of mucus production of the sputum. Investigations. So, general basic lab investigations, peripheral blood examination from patients which reveal moderate to extreme eosinophilia, which may be sometimes at the peak levels when the respiratory symptoms resolve. So, when the respiratory symptoms, like cough, breathlessness, they resolve, after resolution of those respiratory symptoms, even the peripheral blood eosinophilia may go into higher side also. Expected sputum, if present, frequently contain eosinophils. So you can find eosinophils even in the sputum sample also. So, and radiographically, chest X-rays or CT scan shows transient here and there, all over lung fields, migratory, non-segmental interstitial and alveolar infiltrates. Often they are located at the peripheral regions. These lesions radiographically seen at the peripheral parts of the lungs, peripheral and pleural based. Pulmonary function evaluation typically reveals a mild to moderate restrictive ventilatory defect. With a reduced diffusion capacity for carbon monoxide. So diffusion capacity for carbon monoxide is one of the pulmonary function tests. So there will be restrictive ventilatory defect with a decreased this pulmonary function test. So the so-called diffusion lung capacity of carbon monoxide. Pathology. When Loeffler'S syndrome is due to Ascaris lumbricoides, the pulmonary manifestations are believed to result from the hypersensitivity reactions, immune hypersensitivity reaction to Ascaris larvae. Following ingestion of the ova, the larvae hatch within the small intestine initially. So from the small intestine, they crosses across the intestinal wall and enter the splanchnic circulation. So splanchnic blood circulation, they enter into splanchnic blood circulation. From the splanchnic blood circulation, ultimately they reach pulmonary circulation. In pulmonary circulation, they cross pulmonary capillaries into the alveoli, and where they mature into adult forms. And afterwards, again, they ascend into the large airways, and from smaller bronchi to the larger bronchi, from larger bronchi to the further they go up and they reach pharynx. From pharynx they may come out again. They may aspirated and swallowed into the gastrointestinal tract. So like this, they complete their life cycle. The pulmonary manifestations of Loeffler'S syndrome begin approximately 9 to 12 days following ingestion of the larvae. 9 to 12 days of following ingestion of the larvae. Okay, and occur during the migration of the larvae through the lung. Ascaris is another large roundworm, which is endemic to pigs, can cause nearly same identical syndrome. But this Ascaris is not commonly seen as that of Ascaris lumbricoides. During mnemonic stage of the illness, Ascaris larvae may be identified in sputum or gastric aspirates. So, Ascaris larvae can identify Ascaris larvae in sputum sample or in gastric aspirates, especially in the mnemonic stage. When there is a pneumonia, when the significant patient has got significant respiratory symptom, and the patient has got pneumonia. Pneumonia is especially. So in the pneumonic stage of the illness, this Ascaris larvae can be identified easily in sputum samples or gastric aspirate sample. In keeping with the life cycle of Ascaris, stool examination for O1 parasites is typically negative until 8 weeks after the onset of respiratory symptoms. So during the respiratory symptoms, when the patient has got respiratory symptoms, generally due to the life cycle of Ascaris lumbricoides parasite, we will not find O1 parasites in stool examination generally. So we will find only sputum sample or upper sputum sample or bronchial lavage. Okay, but not in stool examination. Stool examination detects O1 parasites only after 8 weeks, after the resolution of respiratory problem. Histological evaluation of lung tissue is not required. The histological evaluation of the lung tissue is not required for confirmation of diagnosis. When tissue has been obtained, a characteristic and striking eosinophilic infiltration. So when you send for a tissue for histological examination, the striking eosinophilic infiltration of interstitium and alveolar capillary units have been noted. Increased number of macrophages have also been noted. So along with increased eosinophils, even the increased numbers of macrophages are also noted histopathologically. Tissue necrosis will be there, vasculitis, tissue necrosis very, very occasionally. Generally, they are not the features. Tissue necrosis will not be there, vasculitis will not be there in this simple pulmonary eosinophilia. Treatment. Since Loeffler'S syndrome may be induced by a variety of exposures, a search for an etiological agent like parasitic infection or the drug reaction should be undertaken. So symptomatic treatment like bronchodilators, oxygen supplementation, steroids, with or without other antimicrobials, if there is secondary bacterial infection, may be used for the suppression of the respiratory symptoms. Although these are usually self-limited. In cases due to Ascaris, treatment with oral mebendazole or albendazole 100 milligrams twice a day for 3 days should be given to prevent late GI manifestations, to prevent further progression of the disease of the Ascaris, which induce, because if you further progress the disease without the prescription of the albendazole, mebendazole at the appropriate time, they will again may cause further more problems like diarrhea, abdominal pain, malnutrition, or other intestinal, even intestinal obstruction also is reported in some few cases, typically 8 weeks or more after the onset of respiratory symptoms. Since stool specimens are negative for O1 parasites early in the illness, clinical follow-up over a period of 2 to 3 months is indicated. So generally, clinical follow-up is advised, and we can send stool specimens for examination of O1 parasites after a period of 2 to 3 months only. So other parasitic infections, Infections with parasites other than Ascaris species are also commonly associated with pulmonary infiltrates and blood or pulmonary eosinophilia. So this increased eosinophilia you can find in pulmonary secretions or even in peripheral blood also. The parasites associated with the development of pulmonary eosinophilic syndromes. Okay, all these parasites, not all, other than Ascaris species also can be associated with development of pulmonary eosinophilic syndromes. The prevalence of infection with each of these organisms varies with geographical location. So the prevalence of this infection varies. There are many factors that influence the prevalence of infection: geographical location, socioeconomic status, host immunity. In addition to Ascaris species, Loeffler'S stercoralis, also called as intestinal nematode, Encyclostoma brasiliensis, cutaneous helminthiasis, also called as Toxophora canis, dog roundworm. So dog roundworm, visceral larvae migrants, also called as Toxophora canis, are the parasitic agents most commonly associated with the pulmonary eosinophilia. Generally, all these are noticed in USA, not in our country. But sometimes we find exceptionally in very few cases in our country also. Strongyloids is widely distributed in the tropical and subtropical regions. Okay, this strongyloids can be noticed because it is widely distributed in tropical and subtropical regions. Following initial transcutaneous infection, so initial there will be transcutaneous infection. A Loeffler-like syndrome may occur as larvae migrate to the lungs. So the strongyloids affect the people initially by transcutaneous infection. So they through by skin. So they enter by through skin contact. Initial transcutaneous infection. Afterwards, they may develop respiratory symptoms when the larva migrate to the lungs because of the mimic of Loeffler-like syndrome. Chronic strongyloidosis occurs as a result of auto-infection, whereby non-infectious rapidly formed larvae transform within GI tract into infectious filariform larvae. So these rapidly formed larvae, after transformation to the GI tract, they transform themselves into infectious filariform larvae. So they further penetrate colonic wall or perianal skin and reinfect the host. So this chronic strongyloidosis disease manifestation occurs mostly because of auto-infection. The first they enter into the GI tract, they transform into infectious form. After conversion into the infectious form, they damage the colonic wall, perianal skin. Okay, all the surrounding omental tissue, everything they may damage. Chronic strongyloidosis can be associated with recurrent asthma-like symptoms also that may worsen with administration of corticosteroids. So if you give corticosteroids in this chronic strongyloidosis, it may even worsen the symptoms which may mimic asthma in this chronic strongyloidosis. If the infection is because of chronic strongyloidosis. Hyperinfection syndrome. What do you mean hyperinfection syndrome? This hyperinfection syndrome results from accelerated autoinfection and usually occurs in persons. So this hyperinfection because of this parasites, because of this strongyloides, maybe can be because of strongyloides or because of Ascaris species. This hyperinfection syndrome results in persons who has got decreased immunity, defects in cell-mediated immunity. In persons with defects in cell-mediated immunity, such as lymphoma, HIV patients, chronic corticosteroids use. Of course, even other comorbidities like has got significant comorbidities like cardiac disease, cerebrovascular accident, chronic diabetes patients, and all these patients and who are also having underlying GI problems also. These people are more prone to develop hyperinfection syndrome. Of course, sometimes even it may happen in healthy persons also. So, coming to some more different other forms of pulmonary eosinophilia, like this is tropical pulmonary eosinophilia. Tropical pulmonary eosinophilia is characterized by asthmatic-like attacks. Unlike simple pulmonary eosinophilia or Loeffler'S syndrome, this tropical pulmonary eosinophilia is characterized by asthmatic-like attacks. So that they will having dry cough, they may have wheezing attacks. Okay, with also splenomegaly. It is a clinical manifestation of lymphatic filariasis, a parasitic infection caused by filarial nematodes that inhabit the lymphatics and bloodstream. 3 species that can cause human lymphatic filariasis that is responsible for tropical pulmonary eosinophilia, namely Uckerria bancrofti, Brugia hallei, Brugia timori. Infection is transmitted by mosquito vectors like Culex mosquito. Humans are the definitive hosts. Pathogenesis. Tropical pulmonary eosinophilia syndrome is caused by an immune hyperresponsiveness to microfilaria larvae trapped in the lungs. The clearance of rapidly opsonized microfilaria from the bloodstream results in a hypersensitivity immunological process and abnormal recruitment of the eosinophils. So there will be rapid multiplication of the eosinophils because of the immunological process due to this microfilaria larvae. And this, when you send the lab investigation of serum IgE levels, the serum IgE levels extremely alarmingly increase it to an extent of greater than 1000 units per liter. Symptoms: persistent or recurrent cough that gets activated more at night times. Weakness will be there, weight loss, low-grade fever also can be there. Diagnostic criteria for tropical pulmonary eosinophilia include history should support of exposure to lymphatic filariasis. Peripheral eosinophilia count will be greater than 3 into 10 to the power of 9 per liter. Elevated serum IgE levels greater than 1000 kilo units per liter. Increased titers of anti-filarial antibodies. Peripheral blood should be negative. Peripheral blood negative for microfilaria. And clinical response to there should be proper clinical response to diethyl carbamazepine. When you do diethyl carbamazepine, so there should be very good clinical response to diethyl carbamazepine. 6 milligrams per kg per day in 3 divided doses for a period of 21 days you have to give. So all these are the diagnostic criteria for the tropical pulmonary eosinophilia. So this is a very brief topic. So whenever a question like simple pulmonary eosinophilia or low pulmonary eosinophilia or Loeffler'S syndrome is asked, so initially you are supposed to describe Loeffler'S syndrome, also which is also called simple pulmonary eosinophilia, and we are also supposed to mention and describe few points also about other forms of pulmonary eosinophilia that are caused by other species of Ascaris. Should also comment on pulmonary eosinophilia caused by strongyloidosis, few points on chronic strongyloidosis, points on hyperinfection syndrome, followed by few points on tropical pulmonary eosinophilia also. So any doubts? Any doubts, please? Are you able to hear me?
Yes, sir.
Yes. Any doubts? Is it clear? Pulmonary eosinophilia, simple pulmonary eosinophilia, hyperinfection syndrome, tropical pulmonary eosinophilia caused by strongyloidosis. All points. Did you get this? All these points? Did you understand all these points? Hello, are you able to hear me? Any doubts? Welcome. Are you able to hear me?
Yes, sir.
Yes. So still you have 15 minutes or 20 minutes time. If you have any doubts, you can ask please. Did you understand about this pulmonary eosinophilia? The various forms of pulmonary eosinophilia, Loeffler'S syndrome, simple pulmonary eosinophilia, Loeffler-like syndromes, Loeffler-like syndromes caused by other species of Ascaris other than Ascaris lumbricoides. Strong pulmonary eosinophilia caused by strong alveolar, hyperinfection syndrome, tropical pulmonary eosinophilia. How tropical pulmonary eosinophilia is different from simple pulmonary eosinophilia? Did you get all these points or not? Did you understand all these points or not? Hello, are you able to hear me? Are you able to hear me? Hello?
Yes, sir.
Yes, did you get all these points? Did you understand today's topic? Did you understand or not? You want to clarify any doubts? You can clarify if you have any doubts. Hello? 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 Hello, are you able to hear me? Are you able to hear me?
Yes, sir. We don't have any doubts, sir.
Right. So did you understood?
Yes, sir. We did understand.
Okay, you don't have doubts. Okay. Okay.
Thank you, sir.
Shall we close the session?
Yes, sir. We should close the session. Thank you.
Okay. Thank you.
Thank you, sir.
Okay. The phone I picked up.